Okay, good morning, everyone. Welcome to Rapid Fire Retina Medical Update Session 1. My name is Kenneth Fong, and my co-chairperson is Timothy Lai. Timothy Lai will be presenting the first two papers, so we'll get started. And the first paper is on faricimab for PCV, the week 16 results from the phase 3b/4 SALWIN trial.
And can we set the timer to 5 minutes? I think we are allocated 5 minutes each.
Timer 5 minutes.
Yeah, otherwise we will overrun very badly. Yeah. So thank you very much for joining this morning session. And I'm going to talk about the SALWIN trial. So this is the interim result at the week 16 mark. So these are our financial disclosures. So as you know, the Chennai Lucerne, our phase 3 trial, which looked at individualized faricimab dosing versus aflibercept in neovascular AMD patient. And it showed that faricimab was able to maintain the anatomical outcome and maintain the vision with fewer injections than aflibercept. In the Chennai Lucerne trials, only a small proportion of patients were PCV patients, but as you know, PCV is highly prevalent in our Asian population, and that's why the SALWIN trial was performed to look at the efficacy, durability, and safety of faricimab, which inhibits both Ang2 and VEGF-A in the PCV population. So it's a multi-center trial. We have 9 countries, 38 sites, including sites here in India. So these are the key eligibility criteria. Basically, age over 50 and macular PCV confirmed by the investigator, so not by a central reading center. And we included patients' vision from 24 to 78 DTDRS letters. So all these treatment-naive patients. The study design is actually adapted from that's in Chennai Lucerne. So basically, patient had 4 loading doses, and then disease activity assessment. And if the patient had no disease activity, they would be put on Q16 weekly dosing. Any disease activity, either 8 weekly or 12 weekly dosing in the first year. But in the second year, this is different from Chennai Lucerne, in which these patients has the potential to extend to Q20 week dosing. So this is only study in the faricimab trials, which actually allow Q20 dosing. Let's look at the retention rate. At week 16, you can see very good retention rate, only less than 1% discontinued the study. Most of the patients were male and Chinese, Korean, and Japanese. In terms of best corrected vision, they started with pretty good vision, 64 letters, and most of the patients had reading center to confirm the PCV, so over 77%. If you look at the visual gain, so you can see very robust visual gain, even after 1 injection, almost 1 line of vision gain, and at week 16, it's 7.8 letters. And in terms of the CST reduction, also excellent. CST reduction reduced from baseline of 417 to 270 microns. In terms of drying the retina, faricimab is very powerful. You can see the absence of subretinal or intraretinal fluid got up to 80% or total absence at week 12 and week 16. And this is a very interesting result. These are the patients with the confirmed polypoidal lesions by the reading center on ICGA. And you can see 51% had complete regression of the polypoidal lesion with just the faricimab monotherapy. And you also achieve inactivation of the polypoidal lesion, which means either ICGA not showing the polyp or not showing any leakage signs on the OCT, so no subretinal or intraretinal fluid. 86% was able to achieve this outcome. If you look at other study which are out there, the phase 3 trials, including Everest-2, Planet, and also the more recent Pulsar PCV cohort, you can see with the use of faricimab in this SALWIN trial, it actually did remarkably well. This rate was actually quite similar to almost getting what you'd get with PDT. It's definitely more superior compared with other monotherapy. And in terms of the number of a proportion of patients with no active polypoidal lesion, you can see again 86%. This is only with 4 faricimab injections. So overall, safety was very well tolerated. There was one case of retinal vasculitis, but after looking at the independent image review, there was actually no evidence of retinal vasculitis or intraocular inflammation associated with this case. So just to conclude, faricimab show the early results show that in CELWIN, very robust vision gain and rapid vision improvement in these PCV patients. In activation of polypoidal lesion achieved in 86% of eyes, and then the safety profile is very favorable. So with that, I would like to thank all the investigators in this study.
Thank you, Timothy. So we'll move on to the second paper you're about to present, which is on the port delivery system with ranibizumab for continuous treatment in diabetic retinopathy without center involving DME, which are the 2 years data from the phase 3 Pavilion trial.
Yep. Can I have my slides, please? Yep. Okay, good. Right, so in this next talk, I'm going to talk about PDS, which is another innovation which has been developed recently, and this is from the Pavilion phase 3 trial looking at diabetic retinopathy without any center involving diabetic macular edema. So these are our disclosures. So as you all know, anti-VEGF treatment can improve the diabetic retinopathy severity, and this is based on, for example, this is in the Panorama study, looking at the patient with moderate or severe NPDR without center involving DME, and you can see by giving these patients a regular injection with aflibercept every 16 weekly over 1 or 2 years, you can see about 60% had 2-step or more improvement. But once these patients, they were switched to PRN dosing, you can see there's actually a reduction from about 78% down to about 50%. So once you do not have this sustained VEGF delivery, then you will get a reduction in the effect. So Pavilion trial is actually designed to evaluate the use of port delivery system, which is a reservoir releasing ranibizumab very slowly over time. And these patients were having the refill of the reservoir every 36 weeks. So it's a 5-to-3 randomization. So about 100 patients had PDS initially, and then for the other, they basically had no implant in the first year, and then in the second year, they were able to have the implant and also the refill later on. So prime endpoint is to look at this 2-step improvement in these cases. And the results at prime endpoint show that 2-step improvement was achieved in over 75%, and at the end of the study, it's around 80%. For control group, so these patients only improved little, and these patients actually sometimes required injection of VEGF. And here you can see that with the patient having the implant put in, they eventually also had some DRSS 2-step improvement. In terms of best corrected vision, you can see very nice maintenance of vision. So with the implant, you expected to have a little bit of visual loss, but then it recovered very quickly. And you can see no difference at the end of the study. In terms of central subfield thickness reduction, you can see with the PDS, you can see very good reduction. And despite these patients having no center involving DME, they also had very good improvement in the CST, about 20 microns over 2 years. With the control then PDS implant, you can also see good reduction in the central retinal thickness afterwards. Looking at the complication, this is very important because these are the sight-threatening complications like proliferative diabetic retinopathy and anterior segment neovascularization, and also patients developing center involving DME. And with the PDS group, you can see over the 2 years, this is very low, only about 10%. Control group, you can see initially in the first year, quite a lot of patients had these sight-threatening complications and required additional treatment. And in the supplementary treatment, you can see 99% of patients with the PDS did not require any supplemental treatment. And also in the other group, control PDS arm, also 100% did not require any supplemental treatment. Ocular adverse events, so these well known, so endophthalmitis only 1%. So these are high-risk patients because they have diabetic retinopathy, so they would be considered a bit more high risk, but the rate is very, very low. So just to illustrate with a case, you can see very good in this eye, the study eye. You can see with the implant of the PDS, good maintenance vision, and the DRS score reduced from 53 to here 35 level. The other eye didn't have any implant of the PES with just a standard of care, and you can see actually this progressed from 47 level to 65 with some proliferation of the new vessels. So just to summarize, PDS demonstrated very good maintenance of the DRS outcome. Two-step improvement was able to maintain over 2 years, and you can achieve good disease control, and there's no new safety signal associated with the implant. With that, thank you very much. So I'll next introduce my co-chair, Dr. Ken Fong, and he's going to present on evaluation of retinal function after intravitreal injection of bevacizumab in patients with or without diabetic kidney disease.
Thank you very much, Timothy. One of the key points that we always look at when we're comparing anti-VEGF treatments is the response to treating large PEDs, which has been...
Yeah, sorry, I introduced the wrong talk. So you are going to talk about Tenali-Lucerne.
Yeah.
Serious PED.
Yeah. So this is a subgroup analysis where we are looking at the response of large PEDs to faricimab or aflibercept. So as you know, the Tenali and Lucerne study was a randomized control trial comparing 6 mg faricimab with 2 mg aflibercept with 4 loading doses for the faricimab, followed by disease activity initiation. And then it showed that you could have an extended treatment regimen with the faricimab based on a PTI protocol compared to a fixed 2-monthly treatment regimen with aflibercept as per label. So we know that there's a greater head-to-head anatomical improvement overall for the central subfoveal thickness, and also that there was a more significant absence of subretinal fluid and intraretinal fluid in the aflibercept arm compared to aflibercept 2 mg. Now, this slide probably is the most important slide in the study, where we looked at the subgroup analysis of head-to-head in comparing the maximum pigment epithelial detachment thickness. And you can see even after 1 injection at 4 weeks, there was already a significant difference between the faricimab and the aflibercept group. And this difference got bigger with more injections given. So this was statistically significant at week 12 after the 3rd faricimab and aflibercept injections were compared. So in terms of types of PED, so we looked at the PEDs at any location in the center 1 millimeter or in the central foveal area, and they were both broadly similar. In terms of the type, serous, purely serous, fibrobascular, and fibrobascular only, both arms of faricimab and aflibercept were also fairly balanced. And now what we look at here is the time to reduction of maximum PED thickness by 50%. And this is important because you want to also have the patient getting a greater improvement in the vision and PED reduction as soon as possible. And we showed that 35% of the patients achieved this at week 12 compared with 25% with 2 mg of aflibercept. And here's one of the patients in the study whereby there was a large serous PED with intraretinal fluid with a baseline thickness of 568 microns, and after 3 loading doses of injections, thickness had reduced by 53% with complete reduction of the pigment epithelial detachment. In terms of the presence of patients with PED present at baseline, we found that there was a 50% reduction in the patients after 1 year with the faricimab patients, but this median was not reached in the aflibercept 2 mg group. In terms of the head-to-head, in the head-to-head dosing phase where we adjusted for the mean thickness at each time point, at 4 weeks, you could see that there was a reduction in thickness of 35 microns in the faricimab group, and then this continued to go down. And after week 12, the differences between the 2 mg and faricimab group were statistically significant. And this was faster again in the faricimab group in patients with the presence of serous PED at baseline, where 61% of patients had a 50% maximum PED thickness reduction at week 12 compared to 51% in the 2 milligram aflibercept group. And the time to reduction to maximum PED thickness at 1 year, this was much faster in the faricimab group compared to the aflibercept 2 milligram group as well. In terms of safety profile, there's no surprises. Both groups had very good safety profiles. There was no systemic events reported, and neither we are worried about RPE, pigment epithelial detachment tests, were large PEDs, and we found that this was not significant in either group. So in summary, the Tenaya-Lucent study showed that the reductions in maximum PED thickness favored faricimab during the head-to-head dosing. The 50% reduction of PED was achieved faster with faricimab compared to aflibercept, and this was a well-tolerated treatment and consistent really with the greater and faster drying in the intraretinal fluid and subretinal fluid phase of faricimab. Thank you very much.
Thank you, Ken. So next speaker will be Dr. Taqi Ali. Yep, and he's going to talk evaluation of renal function in patients on bevacizumab with or without diabetic kidney disease.
Good morning, respected chair and our learned audience. My talk, evaluation of renal function after intravitreal injection of bevacizumab in patients with or without diabetic kidney disease. There is no conflict of interest. As we know, the pathogenesis of diabetic retinopathy, I am not going detail, but diabetic nephropathy is another microvascular complication, and 10% people of diabetes mellitus die of renal failure. And diabetic nephropathy is the leading cause of end-stage renal disease in patients with diabetes mellitus. As anti-VEGF is a widespread and established treatment, and in our country, bevacizumab is mainly used in all the hospitals, and this is the off-label used treatment for diabetic macular edema. And surprisingly, vascular endothelial growth factor, it plays an important role in maintaining normal kidney function. VEGF discharge from podocytes interacts with VEGF receptor 2 on glomerular capillaries and causes endothelial fenestration and result in glomerular barrier function. So our aim was the side effects of following anti-VEGF is well established, that elevated BP, increased proteinuria, renal dysfunction, and thrombocytopenia. And diabetic patients demand strict follow-up protocols by not only ophthalmologists, by the nephrologists also, before and after administration of intravitreal anti-VEGF. The rationale of our study was intravitreal injection bevacizumab could decrease the plasma vascular endothelial growth factor level, and the subsequent side effects may occur. The purpose of our study was to evaluate the renal side effects of intravitreal injection of bevacizumab. General objective was that, and the specific objective was to record the serum creatinine level before and 1 month after giving injection third dose of intravitreal bevacizumab, and also to calculate the eGFR, that is estimated glomerular filtration rate, and one by equation developed by chronic kidney disease epidemiology collaboration, and also to record the urinary albumin creatinine ratio before and 1 month after giving the third dose of intravitreal bevacizumab injection. So it was done in our hospital in Dhaka, Bangabandhu Sheikh Mujib Medical University, and study population was, that is, all the patients coming to our department with who needed injection bevacizumab. Inclusion criteria was like that, and patients having diabetic kidney disease was defined as, that is, if urinary albumin creatinine ratio was more than 30 and eGFR was less than 60 was with diabetic kidney disease, and no diabetic kidney disease was if urinary albumin creatinine ratio was less than 30 and eGFR was more than 60. Exclusion criteria: patient who had intravitreal injection within 6 months, patient with other ocular disease, patient with end-stage renal disease, 1/8 patient, and pregnant or lactating woman. Results, the age was distributed, that is 50, 50 to 60, 60 to 69, and more than 70 was similar in both the groups. And in both, that is with kidney disease and without kidney disease, there was male predominance. And our results showed that there is no difference, that is in serum creatinine was equal in the, that is in both the groups. Similarly, eGFR, there was no difference. There is no statistical significant difference between the two groups, and also urinary albumin creatinine ratio, there was also no significant difference in between the two groups. So we want to tell that mean difference of serum creatinine level was not significant. This was found in other study also. Mean difference of eGFR was also not statistically significant between the pre-injection and post-injection. It was also shown by other studies, not only by bevacizumab, but by aflibercept and ranibizumab also. And mean difference of urinary albumin creatinine ratio was also not statistically significant. So in conclusion, I want to tell that intravenous bevacizumab could not influence renal function among patients with diabetic retinopathy. And the present study reinforces the previously revealed effective renal safety profile of intravitreal anti-VEGF in patients with or without diabetic kidney disease. There are so many limitations of our study, and in one center, and wide range of comorbidities of glycemic parameters, which allowed for potential confounding factors. And this study, we only followed our patients for 1 month after injection, so it may vary in later stages also. So our recommendation, a prospective study and a greater focus on at-risk groups such as those with chronic kidney disease, but at least what we want to tell that monitoring of proteinuria should be recommended in patients receiving intravitreal anti-VEGF agents. Thank you, ladies and gentlemen, for your patience hearing.
Thank you, Dr. Tariq. The next speaker is Dr. Paisan Ramvi Wunsuk, and he'll be talking about assessment of the clinical effects of faricimab based on the Yosemite and Ryan trials, and also the real-world studies in patients with diabetic macular edema.
Thank you, Ken. It's my pleasure to talk about the assessment of the clinical effects of the anti-ANG2 with faricimab based on key outcomes in the Yosemite Ryan trials and real-world Retina and FARWIDE studies in DME. It's my financial disclosure. Well, as we know, in DME, there's elevated of VEGF-A, which is in turn cause devasculation and vascular leakage. However, there's another key factor, which is elevated ANG2, which also causes the vascular leakage, inflammation, and fibrosis as well. So the dual pathway medication, like faricimab, inhibit both ANG2 and VEGF-A should have better disease control compared to anti-VEGF monotherapy, and extend durability as well. So in this talk, I'm going to talk about the effect of faricimab in terms of reduction of fluid on OCT, resolution of macular leakage, reduction of hyperrefractive foci, and reduction of ERM. Well, let's take a look at the median time to the first absence of RF first. You can see the faricimab, TNE, or even the Q8, with 7 and 9 injections respectively, can cause absence of intraretinal fluid at 78 weeks compared to aflibercept Q8. 13 injections achieve this 40 weeks later. Well, in terms of reduced macular leakage, you can see faricimab both arms can have like 53% compared to aflibercept in terms of reduced macular leakage area. Here's the example of the case from the study. And in terms of patients with heart exudation, you can see both arms of faricimab can have fewer patients with heart exudate compared to aflibercept. And here's another example for these parameters. Well, in terms of reduction of hyperrefractive foci volumes, you can see both of faricimab arms can achieve this better than faricimab as well. And here's the picture of patients with faricimab treating. And you can see the proportion of patients developing ERM. You can see the blue bar. That's the faricimab Q8. Significantly have a lower proportion of these patients with ERM compared to aflibercept Q8. Here's an example of patients with ERM after the treatment. Well, in terms of real-world retrospective data for both Retina, which is conducted in the US, and FARWIDE conducted in the UK, so we have like 13% of treatment-naive patients in the Retina study, and 32% of patients with treatment-naive in the FARWIDE study in the UK. Let's take a look. You can see the mean injections in months 7 to 12 is only 1.9 injection for the faricimab in the FARWIDE study. And you can see the mean visual gain is about 7 letter gains after only 6 injections. That's FARWIDE. Right, let's take a look at Retina in the US. Well, you can see the mean injections in months 7 to 12 is 1 0.9 injections, exactly the same as in the far right study. And the mean acuity here after 6 injections is 3 letter again. And you can see the mean CST over 6 injections is improving as well. This is from US data. So in conclusion, well, in the clinical trial and real-world data demonstration of disease control with faricimab in DME, in terms of vascular stability, you can see the greater and faster drying and greater reduction of macular leakage and heart exudation with aflibercept compared to with faricimab compared to aflibercept. In terms of inflammation and fibrosis, there's a greater reduction in retinal hyperrefractive foci and reduce the risk of ERM formation in patients with faricimab. In terms of clinical practice in the real world data demonstrated improved vision and anatomical outcome of patients treatment naive in faricimab, and the evidence suggests early interval extension in treatment naive patients is going to be beneficial. Thank you very much for your kind attention. Thank you.
Thank you, Paisan. Next talk is going to be by Professor Andrew Chang, and he's going to talk about similar visual, anatomical, and durability gains observed with aflibercept 8 milligrams treatment, irrespective of baseline characteristics, a post-hoc 96-week pulse analysis.
Thank you very much, Tim and Ken. I'm going to share with you a post-hoc analysis of the 96-week PULSAR trial, in which we will show that similar visual, anatomic, and durability outcomes are observed with aflibercept 8 milligrams, irrespective of baseline characteristics. These are my disclosures. So we are now very familiar with BCVA and CRT responses through to week 96, and that there are comparable outcomes with aflibercept 8 milligrams and 2 milligrams overall. Here we see dosing intervals. This is a swimmer plot in which we can see how individual patients proceed over the week to week 96. And we can see here that if we look at dosing intervals of 20 or greater weeks, that about half of patients receiving aflibercept 8 milligrams by week 86 can maintain this. So this leads us now into a question as to whether the visual improvements that are achievable with aflibercept 8 milligrams versus 2 milligrams are comparable against several patient subgroups. So we'll go through these now in turn. So here we're looking at baseline BCVA, and we can see here that the BCVA and CRT outcomes at week 96 are similar between the aflibercept 8 milligram and 2 milligram arms. We can see here too that the proportion of patients receiving 8 milligrams that are maintained with 20 or greater weeks at the last assigned interval are similar when we look at the different subgroups based on baseline BCVA. Let's look now at baseline CRT and whether this has an effect on the ultimate visual outcome. We can see here that both BCVA and CRT outcomes at week 96 are similar, and also the proportion of patients receiving 8 milligrams that are 20 or greater weeks at the last assigned dosing interval at week 96 is similar as well. If we now look at the lesion type, that is the baseline CNV, whether it be minimally classic, occult, or predominant classic, the BCVA as well as the anatomic response is similar also. We look also here at the baseline CNV size, and again, there is a tendency to better vision with smaller lesions, but ultimately the BCVA and CRT outcomes at week 96 are similar as well. We also here can look at subgroups stratified according to Asian and white races, and effectively there are really no similar differences in the ultimate visual outcomes at week 96. So in conclusion, baseline BCVA, CRT and CNV size was not strongly predictive of the ultimate vision and anatomic responses and the last assigned interval at week 96. There is, however, some numeric trend towards more frequent dosing in patients with more severe disease. Overall, the proportion of patients with the last assigned dosing interval of 20 or greater weeks was similar across the subgroups, around about 50%. Again, a numerical trend was observed towards greater extension in Asian patients versus white participants. These results suggest that all neovascular AMD patients may have the potential to achieve extended interval treatment with aflibercept 8 milligrams, regardless of their baseline disease characteristics. Thank you very much.
Thank you very much, Andrew. Our next speaker is Dr. Liu Ting Ting. Is she here? Yeah, I didn't think so. We'll move on to the next speaker, Dr. Hussein Ameri. Okay, yeah. Dr. Hussein will be talking about comparison of the results of two common genetic testing panels for inherited retinal degeneration.
Good morning. It's my pleasure to present comparison of the results of two common genetic test panels for inherited retinal degeneration. You can scan the QR code and it will take you to the paper that was recently published. This is the list of my co-authors, and this is my financial disclosure, which is not relevant to this presentation. Genetic testing panels are routinely used for the diagnosis of IRD, and in the past few years in the US, two labs started providing free of charge sponsored tests for patients with IRD, and as a result, many patients with IRD got tested. These two, one is Blueprint Genetic, which has 352 genes in the panel, and Invitae 330 genes, and they have 280 genes in common. We wanted to see how these two compare with each other. You can see this is the report that is generated in the left side, Blueprint Genetic, and the right side, Invitae. And for those who may not be familiar, variants are classified from pathogenic to benign based on whether they cause disease or not. And generally, benign and likely benign do not get reported. But if they can determine the labs that this is pathogenic or not, then they would report it as variant of unknown significant, or VUS, which is the most common reported variation. So this was a retrospective study in single academic center with genetic testing reports being compared for the results and for the updates or amendments that were generated for each. You can see we had 216 total reports, 109 for Invitae and 107 Blueprint Genetics. And there was no difference in terms of age between the two groups, but there were more female in the Invitae group compared to Blueprint Genetics. The mean number of variants per report was significantly higher in the Invitae, both for pathogenic and likely pathogenic. You can see is at 0.9 and 4.1 compared to 0.6 and 1.5. The result, overall, both labs together, 38% were positive. Invitae was 35% positivity rate, and Blueprint Genetics 42%. You can see the breakdown by the inheritance. What was really different between the two labs was the number of amendments, basically updated reports that came later on. And you can see Invitae had 59 amendments. In some cases, they had even 2 or 3. And as a result, 79 basically variants change the type. And this compares to Blueprint Genetics that only reported 3 amendments. We wanted to see how these amendments change the variants. You can see that in Invitae that reported many, 66% VUS changed to benign, and in 20% VUS changed to pathogenic. The effects of amendment on the overall test results was not a lot, but still significant. You can see that in 12% in the in vitro group, basically in 7 patients, the result of their test changed. In 2 of them, negative to carrier, and in 5 of them, negative to positive. Blueprint genetics in 2 out of 3 changed, meaning that Blueprint really only basically issued amendment if there was a change from pathogenic, VUS to pathogenic, or likely pathogenic to pathogenic. But this is the 7 patients that got tested by both labs. You can see that there is none of these 7 patients, the genetic testing report was the same in them. Number 1, you see a patient with cone dystrophy. Even though all the genes that reported here were common in both labs, you see that they differ in that VUS only reported in 2 in Blueprint genetics, and in VT 2 additional 1. Then we have another one you can see in patient number 5 that TTPA was reported as pathogenic where, in Blueprint genetics, and then VUS in vitro report. And similarly, in patient number 7, TMM231 was reported as pathogenic in vitro, and even though this gene existed in the panel for Blueprint genetics, it was not reported at all. In conclusion, genetic testing laboratories employ different methods for variant detection and classification, and they differ in the number of variants reported, differ in the amendments they present, and the vast majority of amendments reclassify a VUS to benign. And this is important because sometimes we see that some patients, actually they say that I have been told that I have this gene, and then when you look at their reports, it's actually just VUS. So it's good to know that VUS a lot of time would actually change to benign rather than pathogenic. With that, I would like to thank you for your attention.
Thank you. Next talk is going to be by Dr. Rajana Mathur, and the talk is titled Implication of Presence of Telangiectatic Capillaries in the Management of Chronic Cystoid Macular Edema in Retinal Branch Retinal Vein Occlusion.
Thank you, Timothy. Ken. So I have no financial disclosures for this talk. Why are we looking at these aneurysmal lesions that we call TELCAPs? Now, if you look at the literature, you'll see they have been defined by either being called retinal capillary macroaneurysms by Spade group, where the lesions have to be at least 200 microns and above, or PVAC, which may be exudative or non-exudative, again seen in different scenarios. But we are going to concentrate on TELCAPs. These lesions, which are supposed to be of diameter ranging from anywhere from 150 and above, originating from either capillaries, but mainly in collaterals or telangiectatic vessels. Pathogenesis could be anything from capillary hydrostatic pressure or loss of parasites or even muscle cell death. And why do we need to understand these lesions? It's because they're not always easy to identify clinically, but they have implications in management of a patient, especially when they have chronic macular edema, and then we may be able to reevaluate their management. It is a retrospective studies of 14 patients of 15 eyes, predominantly male. Hypertension and hyperlipidemia being the commonest risk factors, and diameter of TELPAC anywhere from 450 to 197 micrometer. To note, they were seen both in ischemic as well as in non-ischemic RVOs. And I use multimodal imaging in my patients to come to a diagnosis and to manage these patients. Now, this was the first patient I saw in 2011 when this was not a very well-known entity, where despite 2 years of treatment with anti-VEGFs, the CMO would not resolve. And if you look carefully, you can see that orange lesion, which is really a TELCAP, which was there even at presentation, but probably not so well seen then. But in the chronic phase, where you can see that now it is surrounded by circinates, hard exudates, and in the center there is this thing, and it is quite large. Despite that, because I am from Singapore, we did ICG because we wanted to rule out there is no polyp. And so the polyp was not there, and these TELCAP lesions, which are now known to be better defined on ICGA, could be seen. in this patient very well. And so the patient underwent focal laser, CMO resolved, but of course the patient did not have a very good visual outcome because of loss of EZ from chronic macular edema. So this would be the reason why you may want to know why the monotherapy is going to be important when you're going to introduce laser. I wanted to see what are the factors which make some of these telcap lesions common in RVOs but not in the others. So let's look at each one of them. And as you can see, hypertension and lipidemia were the commonest risk factors, and although in our patients 50% of them also had POAG, diabetes was not common. So is it the chronicity of the lesion that causes edema that causes the problem? So I looked at that as well, and if you look at the first patient, I could see the telcap in the first presentation, but it became more evident. This is another patient where it is a chronic lesion which only presented when the telcap started leaking, and you can see telcap clearly on the color photos as well as on the OCT. So in our series, at least, telcaps were not seen in acute phases. They were more common in a chronic presentation and some in subacute phases as well. Clinically, can you identify them if you look closely? Yes, you can. The triad of 3 signs that I see in my subset of these patients is succinate ring or exudation, lipid exudation that comes on suddenly, which did not exist before. Sclerosed vessels, which may be there, so it may indicate that this may be an acute and chronic process. And you can see that chronically the sclerosis becomes more evident, or even just the large aneurysmal lesion. So this is the triad of some signs that you may see clinically, and you may suspect that the patient has telcap, and you may want to treat them accordingly. And this was the incidence. Again, sclerosed vessel was highest, followed by exudation, and then the orange lesion that was seen. We did not see disc collaterals in any of our patients. What about OCT? Commonest investigations available everywhere. Did that give us some idea? Yes. If you look at it, there is this heterogeneous lesion, which is not transparent like you would see in a microaneurysm, and that may be because of intraluminal material, that may be stagnant blood or lipids that causes them to look so heterogeneously hyperreflective. You may also have hard exudates, and you may also have nerve fiber edema that is more for prognostication rather than for diagnosing the telcaps. You may also want to use OCT to monitor after your treatment whether these telcap lesions are becoming smaller or not. So angiographically, is there anything that I can see to make things better? Yes. If you look at the third and the fourth points, in our series, we could even show them with fluorescein, and all of these telcaps actually arose from telangiectatic areas or collaterals, and they were seen both equally well in ischemic as well as non-ischemic RVOs. This is a patient who had already had laser and was the one on the left. He was already quiescent, but then he presented a telcap lesion much later. You can see that the watershed area principle is disrupted, and you can see this in the inferior area. This was on the left is the previous patient that I showed you. This is again another example of telangiectasia showing that telcap lesion is coming on.
Can you finish up because your time is up?
So, I'm sorry. So just to summarize, OCTA was poor detection technique in our case, and choice of treatment was also not associated with any lesion specifically that's seen. And this would be my take-home message, that you can see clinically, OCTA may not be helpful to identify them because of the stagnant blood, and early detection and combination therapy may be key to better outcomes. Thank you
very much. So our next speaker is Dr. Adil Chowdhury. Dr. Adil Chowdhury, is he here? Okay, so Dr. John Grigg.
Thank you for the
Video? Yeah, okay.
opportunity to present the outcomes from our study into the investigation of oral retinal binding protein 4 antagonist in the treatment of childhood onset Stargardt disease. Unfortunately, I'm not able to be there in person. However, Professor Heinrich Scholl is in the audience and will be able to answer questions at the end of the presentation. So this is a phase 2 study of Tinlarebant in adolescent Stargardt disease. It was an open label study in those with genetically confirmed Stargardts aged between 12 to 18 years. All subjects showed only questionably decreased autofluorescence lesions at the baseline. The primary endpoints were ocular and systemic safety and tolerability. The secondary endpoints, the main ones were change in fundus autofluorescence, as both definitely decreased autofluorescence and questionably decreased autofluorescence, and also the change in best corrected visual acuity. We also measured OCT, microperimetry parameters. So Tinlarebant binds a retinal binding protein 4, and this alters the transport of retinol or vitamin A from the liver to the retinal pigment epithelium. This normally retinol enters the visual cycle in the RPE and then is converted to the 11-cis retinal or part of the phototransduction. In Stargardt's disease, the all-trans retinal, instead of being progressed to regenerate through the rest of the visual cycle, is diverted to an alternative pathway where retinal dimer lipid complexes are formed, which then lead to cytotoxic bisretinoids and ultimately cell death. By limiting the amount of vitamin A entering the visual cycle, the hypothesis is that there is less of the all-trans retinol going down this alternative pathway. So what were the outcome measures? So we're looking at change in best corrected visual acuity. This stabilised during the study. There was a mean loss of 5 letters in the cohort over 24 months, which is equivalent to 2.5 letters lost per year. With information on 6 subjects, where their pre-enrolment mean bilateral loss of vision was approximately 10 letters per year. For this cohort, at the 24-month data period after 24 months of therapy, their rate of vision loss had reduced to 3 letters lost per year. When we looked at fundus autofluorescence, there was 2 lesions that we looked at, the questionably decreased autofluorescence shown on the bottom left and the definitely decreased autofluorescence. These are based on a grayscale on pixel by pixel, with the optic disc taken as a reference point with 100 as a score of how black it is. Definitely decreased autofluorescence on a scale of 70 to 100, and questionably decreased was less than 70. So in 5 of the subjects, there was no change in questionably decreased autofluorescence size, and there was no progression to DDAF. In 7 of 12 subjects, the DDAF lesions were relatively small. When they did occur, they were within QDAF lesions, and the mean DDAF lesion size growth among all subjects over 24 months was 1.2 square millimetres. When we looked at the incident DDAF lesions and compared to the natural history, so in 7 subjects, they developed DDAF lesions between 6 and 24 months. 4 of these subjects developed DDAF lesions after month 12, and the mean DDAF lesion growth rate at 24 months was 0.51 square millimetres. We then compared these results to age-matched ProgStar subjects, which is a large natural history study, and we looked at the subset that were adolescents. So we can see on the graph at the bottom left that the red line is the change in area of the definitely decreased autofluorescence, and in blue is the natural history ProgStar data. And we can see that there's a significant difference between the two. And when we look at the raw figures, at 24 months, the treated group was 0.51 square millimetres, whereas those in the ProgStar group had lesions of 1 square millimetre. So almost a 50% reduction with the use of the Tinlarebant. So to summarise the study, the Tinlarebant led to a sustained reduction in retinal binding protein 4 of approximately 80% over 24 months and was safe and well tolerated. When looking at definitely decreased autofluorescence, there was no incident DDAF lesions in 5 of 12 subjects over 24 months, despite the severity of the ABCA4 mutations. The mean incident DDAF lesion growth rate in 7 of 12 subjects was significantly lower, approximately 50%, than the natural history growth rate observed in adolescent ProgStar subjects with similar baseline characteristics. There's a profound slowing of growth during the 2nd year. Interestingly, sibling subjects with identical ABCA4 mutations showed different rates of QDAF and DDAF lesion growth. The BCVA stabilised over 24 months with a mean loss of 2.5 letters per year. Delayed dark adaptation and chromatopsia were mild and transient. These were expected due to the mechanisms of actions of the Tinlarebant. There's no drug-related systemic AEs. And finally, collectively, data from the phase 2 study indicate that reduction of retinal delivery to the eye with Tinlarebant is a promising approach for the treatment of Stargardt's. Thank you for the opportunity to present this data.
Okay, so next rapid fire will be by Dr. Pradeep Kumar. And the talk is titled 5-Year Outcomes of Apneuron in Central Serous Keratinopathy.
A very good morning to everyone. I'll be talking about our results with eplerenone use in acute CSCR, how we were able to prevent its conversion to chronic. Let me start. Yeah. So we all know that there are differences between acute and chronic CSCR, but interesting thing to note is that even when a patient presents in acute stage, if we look at the number of leaks on FFA, or the autofluorescence pattern showing more than 1 disc diameter size of RP or RP tracks, we know that these are the patients who are more likely to convert from acute to chronic CSCR. Now, when we are supposed to treat CSCR with central leak, these are our options available. But out of these, in our country, we do not have access to photodynamic therapy. So the only option remains between micropulse laser and eplerenone. These are the modifiable risk factors which all of us address in CSCR. The important thing to note here is serum cortisol, and we started measuring baseline serum cortisol levels in all patients of acute CSCR. In absence of a standardized protocol, we do not have a benchmark to perform a RCT with CSCR. So the crux issue remains that out of the two options which were available to us, that is micropulse laser and eplerenone, there are two published studies which stand against the evidence to both of them. But after 2021, when the Vichy trial results came, they were quick rebuttals, and by 2022, 62% practitioners in India were still using eplerenone somewhere in their CSCR management. And by 2024, we had an Iranian RCT which showed that there were higher BCVA gains when eplerenone was used in acute to chronic CSCR. The drug also has a niche space in preventing conversion from acute to chronic, has been reported from our country in 58 patients and in patients of CSCR who develop cystoid degeneration. So what we wanted to study was that whether usage of eplerenone was going to impact conversion of acute to chronic phase. The efficacy as far as its effect in chronic CSCR is inconclusive, but let me show you in my slides how we were able to prevent conversion from acute to chronic. So we started a prospective RCT in 2019 with CTRI approval. Initial plan was to conduct it for 52 weeks with usage of eplerenone. We soon realized 1 year is too short a time to comment on CSCR. We took an extension for 5 years, and we were able to recruit 84 patients in this study. 2 groups were decided, Group E, that was the eplerenone group, and the placebo group. And FFA, ICG, and OCT macula were done at baseline to exclude all other PK choroid spectrum diseases out of our group. And we were monitoring BCVA, contrast, and 10-2 perimetry in these patients. After 1 year, we also added an option of rescue laser. So out of these patients, at the 5-year follow-up, the eplerenone group was performing slightly better than the placebo group when we were talking about the neurosensory detachment persistence. The best corrected visual acuity did not vary too much at 0.4 in eplerenone group and 0.43 in placebo group, but the contrast values were definitely better in eplerenone group at 0.16 compared to 0.04 in placebo group. Also, you can see the perimetric data was slightly better. When we looked at the duration of neurosensory detachment in the entire 260 weeks observation period, eplerenone group had about 8 to 9 weeks of neurosensory detachment, while the placebo group had around 16 to 17 weeks of neurosensory detachment. The rescue laser was required in only 9 patients in Group E and about 17 patients in Group P. So in conclusion, what we wanted to say was that we can always use eplerenone to prevent conversion of acute to chronic CSCR. Let me just show you one of our cases quickly. So these are all the risk factors we evaluate. A patient goes through a fundus photograph, an autofluorescence, an OCT. We do an FA, see a smokestack leak. On ICGA, we look at the choroidal hyperpermeability. We monitor the patient. Eplerenone and alprazolam are started. In March 24, this was the neurosensory detachment. It reduces by May 24. By 21 September 24, we have a clearance. And patient not only improves best corrected visual acuity, the color vision and the contrast sensitivity also improve. So our take home is that try this drug in preventing acute to chronic CSCR conversion, and we have also defined a subset in our paper where you can use it specifically for patients who have a thickened choroid on your OCT, have a type A personality, And when you have measured serum cortisol, your baseline serum cortisol levels are higher. Thank you so much.
Thank you very much. Our last paper is by Dr. Shizhen Chen from Taiwan, and he'll be talking about the port delivery system.
Okay, thank you. I'm going to talk about this the long-term efficacy and safety of the PDS system. That's for neovascular AMD, and this is long-term follow-up for 5 years. This is my financial disclosure. So this PDS system to provide a continuous delivery of ranibizumab. And it is a refuel at office for every once or every 2 times within the year. And this PDS trial, including the velodrome, had been modified, especially for the septum dislodgement. Now, this trial includes a patient in the latest study. The latest study is a study that comparing 3 different doses of PDS implantation, 100 milligram, 40, and 10 milligram. These patients, after the PDS implant, they have a follow-up regularly to see if there any require any supplementary injections. These 3 different groups comparing to a monthly ranibizumab, that is monthly injection of ranibizumab, 0.5 milligram. And after this study, in the average about 22 months, they enter into the portal study. The portal study is all have this 100 milligram implant, and that's including this intravitreal monthly injections group. And these patients will have a long-term follow-up for at least 5 years to enroll for this study. 114 cases were into this was a safety population, and these other 46 patients, they have had 100 milligram in the beginning of the later study. They continues to follow up for 5 years. And this study, we're going to report all these 46 cases and 114 cases. So we can see that after the 5 years of follow-up, the baseline visual acuity in all these cases were, in these 46 patients was 0.5, the visual acuity. And after 5 years, the visual acuity remained 0.5. For the central point, the thickness is about 174, so you can see the remain the same without any increase of the subretinal fluid. So it's quite stable for the efficacy. And you can see that this refill, or this is a supplement treatment. Every time the patient in the last 3 years, every 6 months, they come back for the clinic to see if there are any criteria that fulfill the supplement injection before the refill. So the criteria for the supplemental injection, including that the visual acuity had to be lost for 3 lines, or the patient have increased more than 150 micron of the thickness, or the 100 thickness plus loss of 2 lines. And you can see that during this long-term follow-up, more than about 95% of the patient, they did not receive any supplement treatment. And this is a safety result. You can show that all these 47 patients, they have multiple adverse effects, including cataract, hyphema, and endophthalmitis. But only this hyphema, 1 case, they have a sight-threatening side effects. So in conclusion, this PDS 100 milligram per liter demonstrates stable visual acuity thickness over these 5 years. And then approximately 95% of these patients, they did not need to receive this supplemental injection, and this only the refill over the next 3 years, every 6 months. And the safety profile is well characterized and tolerated. And I thank you for your attention.
Thank you. So we've got about half an hour for question and answer. So I asked all the presenters to get ready. If there's any questions, there's 2 mics there. So maybe I'll start with the first question for my co-moderator, Tim. So when you, in the paper for PCV with the faricimab, the 16-week results from the Salveen study, you showed that the faricimab group had significantly better polyp closure rates. Is that correct?
It's actually it's an open label
Open
study,
label, yeah.
so that's why we don't have any comparison within the trial.
Right.
So I showed a table to compare the results from other study, but the closure rate with faricimab seems to be very favorable.
It's
and
about what? What's the percentage again?
To close the polypoidal lesion of ICJ is 51%.
Right.
But looking at inactivated polypoidal lesions, that's about 81%.
Okay, so that's very similar to the Planet study done 10 years ago, where they showed about 75% plus
Yes.
polyp closure rates.
Yeah, but here it's a bit higher. But if you look at the polypoidal closure on ICJ, that's actually better than them. Yeah.
Okay, thank you. Now, for the PDS, for the treatment for diabetic retinopathy in the Pavilion trial, so there was a reduction in the DRSS score. But in your, just as a helpful for the audience, because we are not routinely giving anti-VEGF treatment for non-proliferative diabetic retinopathy. So perhaps what is the purpose of that trial? Was it to look for visual improvement or just to show that safety and efficacy of it?
Yeah, very good question. So these patients actually have very good vision to start off at because they do not have any macular edema. So they basically has diabetic retinopathy. And as you know, in the United States, anti-VEGF therapy is approved for diabetic retinopathy. So these patients do not need to have any form of a macular edema or proliferative disease. So one of the issues with diabetic patients is their compliance. So a lot of times they are busy with other medical appointments, then they will skip the medical follow-up to see the ophthalmologist. So if you don't have very good screening program and if you do not have these in place, then the patient is very at risk of developing complications from the diabetic retinopathy. And that's why in the sham group, you can see 40% of patients actually developed diabetic macular edema or sight-threatening complications like anterior segment neovascularization and PDR in that sham arm. So with the use of PDS, you put in the device, refill them every 9 months here, and then that can minimize all these complications. So I think it's a good way to prevent visual loss.
Yeah, but I think some aside, I think in the Asia Pacific region, a lot of us still use pan-retinal laser photocoagulation as a first-line treatment, particularly for severe NPDR cases, because again, as you say, these patients don't come back, and also cost issues, having multiple injections with PDS. I think one PRP laser, if you see that patient and then they don't ever come back, there's a good chance you've already saved their vision. So we mustn't forget that.
Yeah, if you have PDR, definitely do PRP laser. That's what I do. And I do combination therapy as well. For severe NPDR, I sometimes also do PRP laser plus anti-VEGF injection. A lot of them will have coexisting macular edema as well, and that's why anti-VEGF is useful. But this study is unique. These patients have dry retina and also included moderate NPDR patients. So these patients, if you do PRP on them, then they might have a high risk of having nighttime visual loss and also the visual field constriction. So I think it's one option, but of course, whether it will be introduced to Asia for these patients, I'm not too sure.
Great. Is Dr. Tariq still? Yeah. So maybe you can go to the mic. When you looked at your patients who you gave bevacizumab for diabetic macular edema, is that correct?
Yeah.
Yeah. So I just wanted to know the reasoning for this, looking at specifically at kidney function, because a lot of the time when we give anti-VEGFs, we are more concerned about these cardiovascular complications, blood pressure, the stroke risk, and the myocardial infarction risk. And then what's the reasoning looking specifically at renal function? And I mean, is there a systemic possibility that the anti-VEGF drug can actually affect your kidneys?
Yeah, it is shown that that is diabetic retinopathy patients, they can develop diabetic nephropathy, and where we are using anti-VEGF, is there any option that is there any effect of this anti-VEGF on diabetic kidney disease? That was our question. And we found that there is no problem. We can give injections with aflibercept. Not only we used bevacizumab only, But in other studies, it was shown that with aflibercept, with ranibizumab, there is no problem with the kidney disease if I put 1.25 milligram of injection. So we wanted to find it out in our study whether is there any problem. What you told that why we took this study is because our diabetic patients, they are suffering from a lot of, say, severe for 10 years, 15 years. So there might be some kidney disease with them. So we wanted to know whether these drugs with kidney disease and without kidney disease, is there any the adverse effects of this drug? So that was our rationale of this study.
Okay, thank you. Yeah, it's reassuring because I think bevacizumab is still widely used in this part of the world. Yeah.
It is widely used. Thank you.
Well, I have a question for Dr. Rajana Mathur. Yeah, very good talk. And for the treatment, unfortunately, you ran out of time on the treatment. So I saw you saying that you plus or minus laser treatment. So actually, for these cases, I actually quite liked doing direct focal laser.
Sorry about that I ran out of time. But what I wanted to show is in our series and also otherwise, the lesions which don't have a very thick wall of telcaps and they're not very chronic, they actually do respond very well to monotherapy. But the patients who come much later, and then those are the ones which are on acute and chronic, with very thick-walled telcaps and larger ones, they benefit better from laser. If the lesion is not very close to the macula, that's the way to go. There was another patient, there was an example to show it was a very tiny, fresh telcap and did beautifully with 6/9 vision. So in my series, there were about 47 patients who did very well with monotherapy and 65 that did better with combination. And one patient, despite combination, had to be on anti-VEGFs because chemo did not respond.
Yeah, combination is probably the way to go, and it can substantially reduce the number of injections because if you don't treat that lesion, then it's likely to need a lot of injections. Right. So that's why I always do combination for these cases. Yeah.
Yep.
Thank you.
Thank you.
I have a question for Andrew about the 8 milligram. You showed, I mean, in the subgroup study showed that there are 3 groups of patients, correct? And all 3 groups had the same response regardless of the 8 milligram. But my question really is, compared to the aflibercept 2 milligram group, what was the durability improvement using the 8 milligram group? Did you mention that in your paper?
No, we didn't.
Yeah.
Well, the focus of this paper really is to look at baseline characteristics, and the clinical implication of that is to see if you can predict perhaps which eyes might do better in terms of increased durability. And when we looked at baseline vision and CRT and actually lesion characteristics, the response was similar. So that was really the effect. It's a post hoc analysis.
Great. Yeah. Yeah.
But in real life practice, we are seeing greater durability with increased molar dose and decreased clearance. That's what the trial did show.
Thank you.
Question for you, Ken, about the PEDs. So these patients, they had large PED, or would you be considering using either faricimab or aflibercept or even bevacizumab, or are you afraid that a very tall PED that might be a rip with a too strong agent?
Yeah, that's a great question. That's always the perennial dilemma we face when we are seeing a large PED in our clinics, and we're always worried about the RPE rip. Generally speaking, brolucizumab remains third line in Malaysia because of the issues with the inflammation. And also sometimes we are worried about a rapid decompression of the PED. That's the thing that generates the rip. So I've had pretty good results with both aflibercept and faricimab when treating these large serious PEDs. But this post hoc analysis was helpful in the sense that it showed that the resolution of the PED was much faster with faricimab. So I think that would help a lot in terms of the stability of the vision gains the patient gets. But in terms of the reporting, we did not show any difference between either arm or RPE rip. So that was quite reassuring.
That's Rajana.
So again, I have a question. You know, when you looked at this post hoc
Yeah, so that mix, that serous, that's, I think there are 4 or 5 categories: purely serous, mixed, fibrovascular, and all 3 groups that we had overall reduction in all three types of PED. So there wasn't really any signal that one type of PED was more difficult to manage than others.
Yeah, and
Sorry, Ken, and what about size or height of the PED?
I think the range from about 800 micron down to about 300. So even with the largest PED size, there wasn't any signal that that group had a higher risk of any RIP. I think that's the one we're worried about. Yeah.
sure. Can you go to microphone, please?
Hello. In the tail cap study, you are saying, so what is the actual time period to intervene? That was not clear from your paper.
So the treatment is going to be whether you want to decide to do the laser, which we know is better. If you can see the lesion, the soonest you can see the lesion is the time to treat it with combination therapy. And I say combination because there are a lot of times these patients, like the first case I showed you, have immense amount of CMO, and there I feel that the combination worked better. Although for that patient it was very late, but for the subsequent patients that did very well, it was because we did a combination at the time we started seeing it defined. So in subacute patients, when they have a lot of blood, this lesion is not very easy to see. And you can do FFA or ICGA, and you can treat it, but when there is blood, you want to wait till some of that blood subsides before you do the treatment. It is individualized, but the sooner the better, yeah.
So one question for Dr. Pradeep. Great paper about CSR, which is always the biggest enigma facing us daily in clinic, where we have these chronic cases. And I know for sure in India, you have much more serious cases of CSR, which is why I think eplerenone remains one of the armamentariums. For chronic CSR, which you define as more than 1 year, is that correct? Would you still give eplerenone for them, despite the fact that there wasn't much improvement seen?
In cases of chronic CSCR, we do give a trial of eplerenone. We try it for about 12 weeks. If it does not work, we try micropulse laser. Still doesn't work. We are working with the effects of anti-VEGF in these cases. We have had a limited data, 9 such patients only, in which we have injected brolucizumab. 7 of them have responded. So when it comes to chronic CSCR and you do not have PDT available with you, you're only left with 3 viable options. So pharmacologically, the drug that we bank upon is eplerenone, and we are using it for 12 weeks. It's a fairly safe drug.
I understand that eplerenone, you can also cause kidney problems. I mean, there's a risk of kidney and hypertension. So is there any pre-eplerenone baseline test that you do for the patients?
So the best part about this is the Vichy trial, which said that we should not use eplerenone. It actually gave us the data that in the control group, they did not have as many side effects during the observation period compared to the eplerenone group. While it was thought of that eplerenone group will show certain systemic side effects, the Vichy trial itself says that eplerenone group had lower number of renal and other systemic side effects, including gynecomastia, compared to the control arm. So to think that the drug itself causes severe kidney problems or gynecomastia is a false notion, though we do baseline RFT values and electrolytes for 3 consecutive visits at 2 weeks. So 2, 4, and 6 weeks. That is all we do.
And what's your dosage of eplerenone for your
50
patient?
milligram.
50 milligrams?
50 milligram.
And just a follow-up question. Have you done any choroidal thickness analysis in these patients? So what's the effect compared
we
with?
did the choroidal thickness. The time was short. We could not show
I know,
everything. So we did the choroidal thickness analysis. It does cause a reduction in choroidal thickness to close to about 80 micrometer. So that is what we recorded. We were using the Spectralis EDI OCT. I wish I had my swept source in 2019. Now I have a swept source. I can actually delineate the choroid better. But the study is based on Spectralis, so that's the data we have, 80 micrometer reduction.
Okay, great. Thank you.
So any other questions? Yeah, one more.
Sir, while using eplerenone, one of the common side effects we have seen is electrolyte imbalance, even in normal patients. What's your take on that?
Ma'am, eplerenone causing electrolyte disimbalance in our series of patients, these are patients 5-year data. 84 patients were initially recruited. They have received on 108 occasions eplerenone for close to about 6 to 12 weeks. There are 2 instances of a potassium increase. 2 instances. The moment the drug was cessated, the values came to normal in a week. So I do not really think that we need to worry too much about the electrolyte disturbance. Till date, the data on eplerenone, which is available with cardiologists also, does not show that any patient ended with either acute or a subacute renal failure due to eplerenone.
So you can stop and restart after?
No, once a patient in which you already have a documented dyselectrolytemia, I will not recommend starting the drug again. Then we have the second and the third option, or micropulse laser, or maybe trying an anti-VEGF.
Thank you.
It's an excellent question, sir. So that is what we said, that in all our patients, in material of whether we are going to keep them in the control group or we are going to keep them in the eplerenone group, we were targeting the modifiable risk factors. So when we addressed the modifiable risk factor, 2 things were there. One was the serum cortisol level, second was the psychogenic state of the patient. So any patient in whom our psychiatrist recommended that alprazolam has to be added, it was given. So that option was available both to the treatment arm and the control arm. And yes, it does help in patients. Nowadays, though, we have progressed a step further, and our drug of choice is mirtazapine. We have stopped using alprazolam.
Okay. So I'd like to thank all our speakers. So we would like to close the session and thank you all for your attendance today.